And I will invite Dr. Rithambara Ramachandran to the podium. She is an assistant professor of ophthalmology with the Division of Glaucoma, and she's going to be talking to us about exploring challenges and opportunities in US-based community eye-based eye screening.
Today, I have no financial disclosures, but the work is only made possible thanks to the K-12 grant, the generous RPP grant to our department, and a mentored physician scientist grant from the American Glaucoma Society. As many of you know, undetected and undiagnosed eye disease is a major issue in the United States. In fact, in 2017, the National Health Interview Survey found that over 93 million US adults were at high risk for vision loss, and yet less than 60% actually saw an eye care professional annually. Just considering the 5 major causes of blindness, we know that 12% of American adults have uncorrected refractive error, which means that they just need a pair of glasses. 50 to 78% of people have undetected and undiagnosed glaucoma. About 50 to 65% of diabetics in the United States don't receive their recommended annual diabetic eye exam. AMD remains woefully underknown by the US population, with less than 30% having ever heard of AMD and less than 2% knowing that it's a primary cause of vision loss. And then even in the United States, cataract is a top reversible cause of low vision, with accounting for about 50% of bilateral impairment. And then unsurprisingly, racial and socioeconomic disparities further exacerbate these issues. Just looking at large national studies, we know that Mexican American and non-Hispanic Black individuals lack proper access to proper vision correction. In addition, low income and education further exacerbate these disparities. The Baltimore Eye Survey study found that there was a significantly higher proportion of undiagnosed glaucoma in African American and Hispanic individuals. Looking at diabetic retinopathy, we know that diabetic retinopathy is 190% more prevalent in non-Hispanic Blacks and 130% more prevalent in Hispanic Americans. And using the large source consortium database, it was found that rural Black Americans had an 88% lower odds of receiving eye care compared to non-Hispanic white individuals, and those on public insurance also were less likely to have access to eye care services. Using the large NHANES data set, they found that AMD was more common in low-income neighborhoods as well as white populations. And really frighteningly, we know that African Americans have a 5 times more likely to have unoperated cataracts, and that 1/3 of individuals under the age of 70 are actually blind from cataracts. And this is in the United States. Neighborhood deprivation also leads to delays in eye care, including cataract surgery. So more individuals present for cataract surgery with worse visual acuity. These statistics really highlight the potential for targeted screening. And to this end, the CDC's Vision Health Initiative in 2018 funded a large SITE program, the goal of which was to come up with novel ways to both diagnose and help with the detection of glaucoma as well as other eye diseases in high-risk populations. It was centered primarily in Michigan, New York City, and Alabama. And me as a glaucoma specialist, I'm particularly interested in the fact that they had detection rates of about 27%, which is over 3 times the national average. But across all of these different eye diseases, you can see that the prevalence rates were really high. And then just as a shameless plug to come and see my poster this afternoon, here we use the source data set, basically leveraging this large data set so that by the time people come to large academic institutions, you already have advanced glaucoma. And this is seen both based on ICD-10 coding, cupping, and intraocular pressure. And this cross-sectional approach is particularly effective to show that especially for diseases like glaucoma, wet AMD, untreated diabetic retinopathy, by the time we're seeing patients in our clinic, oftentimes we've already lost a lot of ground. And so these findings really collectively underscore that there is substantial undiagnosed disease burden in our communities and provide strong evidence for the effectiveness and necessity of targeted screening programs. But part of the reason that screening still remains so controversial is that there's so much variability, be it the type of program, who the personnel are involved, what kind of setting we're looking at, what diagnostic tests we're looking at. And the number of screening programs that exist in the United States far exceed the number that have actually been published about, let alone rigorously studied. And so that brings me to the aim of my study, which was to explore the challenges and opportunities in implementing community-based eye screening programs using an implementation science lens. Implementation science is an emerging field that really looks at not just what, but really how do we take these evidence-based practices and implement them into a real-world setting. And it does so really by exploring the processes, the strategies, and the contextual factors that actually make successful implementation of such programs. And so we conducted 1-hour semi-structured interviews via Zoom. Participants were selected via purposeful snowball sampling, which is a common qualitative research methodology. It was decided our priority to do about 15 to 20 interviews based on previous literature, because that was thought to reach thematic saturation by that point. And eligibility criteria was anybody over the age of 18 with an academic affiliation and who had integral knowledge in the design and implementation of their institution's vision screening program. The interview guide itself was designed by the study team and then analyzed for face and content validity by qualitative methodology experts at the University of Michigan. And the interview touched on these domains listed here, although these were just starting off points. And all the interviews were conducted by one interviewer between May and August of 2024. So the interviews were then coded and analyzed by a member of the Mixed Methods research team here at the University of Pennsylvania, as well as the study PI. The two of them open-coded 3 transcripts, and it was found based on this that the best framework to use would be the Consolidated Framework for Implementation Research. For those of you who are not familiar with CFR, CFR basically deals with 5 different domains. The intervention domain basically describes the core characteristics of the intervention, or in this case, the program, that's outside of any kind of contextual factors. The outer setting is more of the social, economic, and political context with which the intervention is based. The inner setting is the actual clinical setting. The individuals are the actual agents of change. And then the process or the implementation really describes the active process of accomplishing the intervention in question. And so CFR really highlights critical success factors, identifies barriers, and guides tailored strategies to make the effectiveness and sustainability of these screening programs really apply to real-world settings. The team then reviewed any coding differences and resolved through consensus. They double-coded 20% of transcripts to maintain good inter-rater reliability, and then coded the rest of the transcripts independently. So 17 participants were included in total, with about 15 different programs represented. Some were involved in multiple programs, some were involved multiple people in the same program. 11 were female, 12 were Caucasian. And interestingly enough, at the time of involvement with the screening program, majority of them were actually very early career. So majority had done this as their first post-training role, and 9 were assistant professors. The programs were all very varied. Some of them were ongoing, some of them were grant funded and had already ended, some were telemedicine based, some were modeled in federally qualified health centers, community fairs, community clinics. Most of them screened for all eye diseases. 2 of them were specific to diabetic retinopathy. This is a very typical CFR framework, so you can see the 5 domains and how they're interconnected with each other. But this is another way of presenting the same data through a hierarchical tree map, where you see the most commonly talked about domain is in the top left, which is the implementation, and the least commonly is in the bottom right, which is the innovation domain. The size of the boxes correspond to how often these different codes were mentioned by the participants, which is also given in the capital N, and then the number of participants is in the lowercase n. And while I don't have time to talk about all of these different codes, I'm going to highlight some of the most important ones. So implementation of the actual programs was the most commonly talked about, and specifically the codes of assessing context and needs were talked about more than 300 times by all of the different participants. Some of the challenges that were talked about were obviously the socioeconomic barriers that many of these participants face, low follow-up rates, and then the ongoing as well as historical history of medical racism. Opportunities involved giving low-cost classes, having cultural concordance, and then creating spaces that were felt safe and were accessible to all individuals. This particular participant talks about how, particularly in underserved groups, it's really important to make sure that missions and goals were aligned. This one talked about how they tried to do a screening program in a community where basic needs such as food and shelter weren't being met, so eye care was obviously fell much below. This one talked about how important it was to have something tangible like glasses to provide. And then finally, the mistrust amongst a lot of these communities. Unsurprisingly, in the outer setting, finance was a big, big topic. Many talked about the lack of dedicated funding for vision care. A lot relied heavily on philanthropy or short-term grant funding. Challenges included costs of staffing and startup costs, strings attached to funding sources, and then how funding was directly related to sustainability of programs. But opportunities lay in kind of leveraging existing billing codes, low-cost volunteers. For example, this participant talked about the emotional investment that comes with funding fears and fears of grant funding ending. When asked one participant what their advice was for young scientists, they said, just get funded. Many talked about how expensive and labor-intensive funding is. And then finally, some people talked about how helping the vision of one community really helps the vision for everybody, because you're increasing the sited workforce, and yet communicating these kind of messages is not always easy. When talking about inner setting, many talked about infrastructure limitations, lack of standardized workflows, institutional bureaucracy. Some mentioned that they were delayed over a year or two just because of working with their department's legal, their lawyers. Still, many talked about the importance of local partnerships, leveraging IT technology, and then again, medical students came up, although one did talk about the varied quality of medical students and the high turnover rates. And then many, many people had very strong opinions on how screening programs should look like, be it through federally qualified health centers or bringing care into the community. This one participant talked about how community fairs likened it to picking up trash just once a year. Many talked about how frustrating it was that they were just developing protocols kind of on the fly and didn't really know what to do with their resources. And then this participant talked about how challenging a lot of these settings were and things I didn't typically think about, such as, does this setting even have a bathroom? Or what do you do with all the trash that's generated after a screening program? Obviously, every participant talked about the actual screening program and specifically about the complexity of screening. And that really included balancing the multiple priorities of all the different stakeholders. Many of them were very young, and so they were also balancing their own work-life balances. They brought kids to screening events or had to center the screening events around their own family and kids' lives. Many also, emphasized the need for care navigators and the communication throughout the process. And then every single one had really memorable stories about patients that were affected by these screening events. This person talked about how important it was to balance the service-oriented mind when thinking about screening with the bureaucracy and the reality. This one talks about not just screening for the sake of screening, but really how the hardest challenge was then looping people into long-term care. And then again, the many areas of resistance and barriers that people faced. And then finally, every single person talked about how important it was to have strong implementation team members. Challenges, of course, included that staff and labor are expensive, particularly when you're using ophthalmologists and trying to pay for their FTE, how motivation could be difficult, and then thinking about the local environment and having respect for already established eye care professionals in that area. Many talked about the importance of having liaisons or champion within the organization that also kind of knew the local context, but then could also talk with the people in the academic institutions, the importance of training local staff, and then having a project manager just to kind of deal with the complexity of the project. This person said we had a lot of volunteers, but it wasn't a whole lot, but really having optometrists was key for them. This one talked about how they had 20 community health workers, and yet none of them spoke Spanish in a highly Hispanic neighborhood, and how they just did not think about it. And then, of course, the importance of community-based advocacy and community-based recruitment. And so in conclusion, through this study, I don't present a single view of what community screening should look like, but if anything, I hope you get the sense that this really requires a lot of rigorous study as well as consensus building, and hopefully studies like this is a first step towards that. And what's clear is that these programs are complex and deeply contextual. Local needs and aligned missions is really essential. We know that follow-up remains a huge challenge, with follow-ups post-screening about 30%, which means that 70% of people where we detect disease are just completely lost into the community. Screening is costly, time-consuming. Unfortunately, there's very little federal will to support efforts like this, and that even though there's so many really passionate individuals, there's really no guidance or toolkit available. And then finally, we really have to know that the patients that we are serving, it's an upstream battle, right? We have to make sure that our screening events are actually accessible, be it offered at multiple times or times that people can actually participate, and that there needs to be a mechanism to address some of these upstream health determinants. But opportunities remain, especially when programs really keep the patients at the center by offering incentives like free glasses or making it an enjoyable experience. Sustainability really depends on having either leveraging existing billing mechanisms or making billing mechanisms. We have to build strong community partnerships. Education is a big thing. And then, as we've heard today, AI, telemedicine holds a lot of promise, but really they can only be actually applicable and sustainable. And in order for them to succeed, we have to first build and figure out what is a way to have strong programming. And so finally, if you ask me what I think the biggest challenge to community-based screening is, it's the fact that we still have no consensus or definition. As this one participant said, there are roles for screening and for comprehensive eye care. And so in settings with limited health resources, where on that continuum, what is enough for a particular patient? But, despite these challenges, I remain really optimistic. I had such good conversations with these really passionate leaders, and it really inspired hope for like a national roadmap or toolkit to support effective programs. As one participant said, the time is now to get the community working together. None of us are by ourselves. And, even though we don't have the wherewithal, we're also focused on our individual projects. It's a real miss nationally, and that if we put our heads together, we can actually have the evidence to power things. It's an amazing opportunity given the importance of vision. And, for the US right now, we're not performing well, and that's a real tragedy. But in tragedy, you get opportunity. And so I want to thank everybody, all of my mentors, and definitely all the participants who donated their time and shared their experiences. Thank you.
Any questions? Oh, Marissa, please.
So you mentioned that accessibility was kind of an issue. How do you think that mobile screening units might fare with this? And I'm just curious to know, were any of the individuals that you interviewed involved in something like a mobile screening?
Great question. The question was about accessibility and how accessibility is an issue and how mobile vans deal with and whether we had any participants. So yes, we had a couple of participants who did some version of a mobile van. I think accessibility is a very broad category, right? So many talked about accessibility in terms of physical space. And that's where sometimes mobile vans, depending on how things are structured, how are you thinking about accessibility? Are you thinking about physical accessibility? Are people coming up? And then are you thinking about people who already have physical impairments, right? Can they actually, are they mobile enough to use the mobile van unit? Are you thinking about, you have to think about accessibility in terms of like all of the different domains. And I think people often don't realize that until they're actually part of the program. So mobile vans might address one, but it doesn't kind of help everything. Yeah, so there, like I said, people were very, very opinionated about what model they thought, and some thought that mobile vans was not a good model because of the idea of sustainabilities. Other thought that if you're going to do, let's say, a primary care-based clinic, right, that's especially when we're thinking about AI and DR, a lot of them are doing in primary care, you're reaching the people who already have access to care, right, who are already in primary care units or have a PCP. We're missing the whole swaths of community who have no connection to healthcare. And so mobile van units are a way to actually go into the community and potentially access those patients. So like I said, people have very strong opinions one way or the other.
What are some of the things you're going to do for follow-up in the community, particularly with the changing landscape of insurance for patients?
In terms of
making sure when you screen someone in the community that they actually have appropriate follow-up if disease is identified.
Very complicated question that a lot of people who are in this space are thinking about and studying as to what are those, first of all, understanding what those challenges to follow up are, right? Why are people not following up? Is it because they want to follow up, but when they call, they make an appointment with the eye center, and then when they call, they reach an automated machine and they're never able to actually make that appointment? Is it because they try to go and then last minute they don't have childcare? So I think, first of all, understanding that local context part of it is why people are not following up is important. And then only can we, I think, tailor the right strategies.
Thank you.